Hi, everyone. My name is Dr. Wes Boyd. I am a psychiatrist in Houston, Texas. I'm on faculty at Baylor College of Medicine and am a professor of both medical ethics and psychiatry there, as well as on faculty at Harvard Medical School. Today, I'm going to be talking about medical ethics and in particular, ethical issues concerning end-of-life care. And with that, I'm going to share my screen about ethical considerations and issues at the end of life. In addition to being a faculty member at the Baylor College of Medicine, as you can see, I'm also at a VA medical center, that's Veterans Administration Medical Center here in Houston, Texas, and am co-chair of the ethics committee at that facility. Some of the cases that I'm going to discuss in this presentation actually are cases we've seen at our hospital here in Houston. Particulars have been changed, names have been changed, identifying features have been changed, so the individuals are not going to be identifiable in any way, but nonetheless, these are real cases. I don't have any financial disclosures to discuss, and I have several objectives for this talk. First of all, I want to understand and discuss basic medical ethical principles. That'll be on the next couple of slides. Also, recognize the rights of a patient to refuse or limit care, even when that care might be life-sustaining. So this is something that can be very difficult for medical teams. That is namely when a patient is very sick and requires certain medical procedures or surgeries, for example, to save their lives, and the patient says, actually, no, I'm not going to accept that care. So I'll talk in depth about that, and then also talk about the role of decision-making capacity. So capacity is something we talk a lot about in medical circles. Capacity is different from competence. But when patients have capacity to make decisions for themselves, we have to respect their rights to do so. Again, even if that decision might cost them their lives. And then also think about who might serve as a surrogate. So who can decide for another person when one person is incapacitated or lacks capacity. So what is bioethics? Bioethics, not surprisingly, is the application of ethics and ethical principles to medical situations, so medical practice situations, as well as medical research situations. Ethics is, as you know, the study of right and wrong, moral duties and obligations. There are lots of theories in ethics about how one ought to proceed. But when we talk about medical ethics, we are applying all of those considerations of ethics, again, to medical situations. Also, bioethics is different from the law. They often overlap with one another, that is bioethics and the law, but they're not the same thing. For example, if I am driving 57 miles an hour in a 55-mile-an-hour speed limit, and I'm not endangering anyone, but I am going 2 miles over the speed limit, I might be breaking the law, but I'm not doing anything remotely unethical. By contrast, if there are lots of situations in people's personal lives where they are behaving in an unethical manner, say in romantic relationships or business dealings, in ways that might be unethical, but might not necessarily be breaking the law. And then the other thing is that, and this really actually makes my job quite interesting and fun, bioethical dilemmas almost always involve competing interests and principles. So if a situation was just dramatically straightforward and it was 100% clear what you needed to do in any given situation, it's not going to be that interesting. But dilemmas come up because principles end up butting heads with one another when people are trying to figure out the right way to proceed. At this point in Western medicine, there are 4 basic ethical principles. I've listed them here. These, at this point, are more or less etched in stone. And so literally, this is the right answer on a test if you ever see questions about ethical principles. And I had this question on a test in 2009 when I was taking my recertification exam as a psychiatrist here in the US. And there was a very long paragraph describing a patient scenario. And the question at the bottom of it said, which ethical principle is mostly at play here? And only one of these 4 words was listed. So I already knew the right answer without even reading the long paragraph. All right, without further ado, the first ethical principle is autonomy. And I've already hinted at this a little bit around, considerations of capacity, but autonomy is the principle of letting people decide for themselves what they get and what happens to their bodies. Simple as that. We're going to respect autonomy at this point over and above these other principles, provided that an individual is thinking clearly and rationally, right? So if you have and also they need to be an adult. So if you have a 2-year-old kid or a 5-year-old kid who's kicking and screaming and saying, I don't want to go to the doctor, or I don't want to eat my dinner or whatever, we're not going to respect that kid's autonomy. No good parent would do that. At the other end of the life spectrum, if you've got someone who might be older, but they have a neurocognitive disorder or a dementing disorder, Alzheimer's dementia, for example, is the big one. If someone is demented and not able to think clearly and rationally, we're not going to respect that person's autonomy. But all other things being equal, at this point, we respect individuals' rights to choose for themselves what happens to their bodies. The next 2 principles really are flip sides of the same coin. The first one is non-maleficence, which is either preventing harm from happening or not doing harm. Both of those count as non-maleficence. Beneficence is the flip side of that, which is trying to do good, right? And do things that promote good and help other people. Anytime we provide medical care, we are trying to balance these 2 principles with each other, because any remedy or treatment that can potentially help someone can also potentially harm them. Any medication, even medications that might be life-saving, can also carry with them the possibility of side effects, generally speaking, or even anaphylaxis, which is when you go into shock and have trouble breathing, and that's a life-threatening emergency. Anaphylaxis is always a possibility when you give someone a medication. So we're always trying to balance the goods and the harms for any medical treatment that we offer. And then justice is the 4th principle, and that really is thinking about ethics and ethical issues from a societal perspective. And we start thinking about distributing goods and treatment fairly and equitably. So for example, when the vaccines for COVID first came out and there were debates about who ought to get vaccinated first. Some of the options were, should we vaccinate old people first? Should we vaccinate sick people first? Should we vaccinate healthcare workers first, right? There were lots of considerations there of goods and potential harms, but the big question in deciding how to distribute the vaccines when they first came out were really questions about justice. So it's thinking about distributing goods or treatments fairly and equitably across from a societal perspective. So now I'm going to shift gears, since I was talking about autonomy, and think about capacity. And again, capacity is what people need to have to be able to make decisions for themselves. There are as you can see, there are 4 basic elements of capacity. The first element, and again, this requires that the individual use reason and logic in being able to talk about whatever the given problem is. So when you're thinking about capacity, you're thinking about a specific situation. Does this person have capacity in this situation to make a decision here and now? And here are the things you need to consider. Do they understand the facts? Simple as that. Do they get the fact that there is a disease process in their lower left extremity, or whatever the other facts are, right? They also have to make a choice. So, and the choice has to be consistent over time. So they can't say, I would like an amputation. The next day they say, I don't want an amputation. The next day they reverse course again. They need to voice a choice that is consistent across time. In addition, they need to appreciate the nature and severity of their illness. So for example, if someone, the medical team says someone needs an amputation in order to keep them alive, and the person repeats back to you, no, I wouldn't die if I don't get the amputation. I just might have a little fever. Then in that case, we would say they do not appreciate the nature and severity of their illness, quite obviously. And then also the last component is that they need to be able to reason. And I've already talked about that at some length. So these are the 4 elements of capacity. When they are all present, we can say an individual is able to make decisions for themselves. When should a medical team think about deciding whether or not a patient has capacity? First of all, when I would wager almost everyone on this call goes into a doctor's office, or I go into a doctor's office, overwhelmingly, the doctor's not sitting there saying, man, I wonder if Dr. Boyd can make decisions for himself about whether he gets this medicine for his blood pressure, or he gets this operation or whatever. They're just, if I'm talking reasonably and they have no reason to doubt my intellect and ability to understand things, then they're not going to formally assess capacity. They're just going to assume capacity is there. Simple as that. That's what most of us do all the time. A more formal capacity evaluation ought to be considered when a patient is obviously or in some way doesn't seem to be thinking clearly or really understanding what's going on. What kinds of situations might that be? That's this third point here. Such reasons include a real acute change in mental status. So if someone goes from being highly alert to now they're groggy and confused and appear, or even intoxicated, who knows? Or the second point here is what I see a lot in the ethics work that I do here in the hospital I work at in Houston, when someone is refusing a clearly beneficial recommended treatment. So again, the example I've seen more than once here in my hospital, but also I've already used here in this call, is if someone is refusing, say, a amputation that the medical team says is absolutely necessary to keep someone alive. When someone is refusing what the medical team believes is life-saving care, you better assess capacity because the stakes are very high. And so on and so on. I'll leave it at that for now. Who can determine capacity? It actually can be done by any of the licensed medical providers and psychological providers for any given individual. So just like your doctor, when you go into your primary care office, is making an implicit assessment of your ability to make decisions, implicit assessment about your capacity. Doctors do it all the time. Physician assistants can, so that's PAs, nurse practitioners, NPs, psychologists, medical doctors, and doctors of osteopathy who don't have any particular psychiatric training. So all of these people can make determinations. Psychiatry or psychology doesn't have to be consulted at all. So some people inappropriately think that, oh, in order to assess capacity, you got to get psychiatry or psychology involved. That's absolutely not true. But if you're in a large facility which has those services and it is a question of life and death, you may well want to get psychology or psychiatry involved to really make sure that you have exhausted the ways in which you have of making sure that person is able to make a choice for themselves. Ultimately, as I say here, the treating provider is the one who determines capacity. Our ethics committee at my hospital, that's what the big acronym MEDVAMC, that's the acronym for my hospital. We don't make those determinations, even though I am a psychiatrist in my role as an ethicist here at this hospital. I leave determinations of capacity to the medical team. So what's the difference between capacity and competence? Competency really is a legal term And competence is determined by judges, not by clinicians. That's the big one. I've seen people who have been declared incompetent by courts decades ago, and at that point, they don't have the legal right to make any decision on their own behalf. So for example, real estate purchase, they can't make that call. Consenting for a major operation, they can't make that call. If they go into a doctor's office and the doctor wants to draw blood, no one's going to question their ability to say, sure, go ahead and draw my blood, because that's a very minor procedure, very, very low risk, knock on wood. Hopefully, usually is. But for any real decision, a large purchase, operation or something like that, if someone has been declared incompetent, they're going to have a guardian or a surrogate decision maker making the call for them. Capacity, by contrast, is a clinical decision, not a legal one. And this third point under capacity is really important. It can change from moment to moment. It's not an absolute or permanent decision. And also, it applies to a very specific situation. Someone might have capacity to say yes to a blood draw, to say yes to buying groceries and making minor monetary decisions for themselves, but not have capacity to either consent or refuse major surgery that might be life-saving. So again, capacity can change from moment to moment. So for example, if I'm unconscious right now, then I obviously can't voice a choice, and I am not able, that in a way that anyone can see externally. If I'm unconscious right now, no one can see that I'm able to use my reason and rationing capabilities to make a choice. And so if I'm unconscious, I inherently lack capacity to make calls. If I wake up and 2 hours later I'm fine, lo and behold, then I have capacity. Or if I have, waxing and waning mental status changes, there are times when I might be fully alert and able to use my rational capacities. I therefore have capacity then, but if I fall into a stupor after that, then I lose capacity. So again, capacity really can change from moment to moment, not an absolute call, very different from competency, which is a legal determination. Informed consent, what is it? That is the need of patients to be fully informed about any medical procedure that someone might want to do on them, and except in certain emergencies. Again, I've said this before, patients are free to accept or reject treatment, even if it's to their own harm. And what are the principles that come into play when we're thinking about informed consent? Informed consent, we want to respect people's autonomy, and we are trying to, again, balance the risks and potential harms of any treatment with the potential for helping the person. So I'm going to talk about this case. This is, again, a real case. All the details have been changed of the individual, including the name. Mr. Sweet is a 62-year-old man with diabetes, end-stage renal disease, and a right above the knee amputation. So he's already had one amputation with lower extremity osteomyelitis. He developed a non-healing foot ulcer on his left side. So he already has a right amputation, a right above the knee amputation. Now he's got a non-healing ulcer on his remaining left foot, and the entire medical team, infectious disease, which is what ID is, vascular surgery, and his primary medical team all recommended amputation, but Mr. Sweet said no. The medical teams were worried that if he didn't get that amputation, he was going to die. And so lo and behold, as it says in the right corner in this slide, this definitely caused consternation. Can he say no? I'll ask you that question. Is he able to say no? And right now, I hope you're saying, we don't have enough information, because you know what? I didn't give you enough information to make a call yet. And so that's why I say it depends. What does it depend on? Hopefully you know the answer, but here we go. If Mr. Sweet has capacity, then we say that he is quote unquote decisional. That's sort of a shorthand way of saying he's got capacity and he can make choices for himself. And now this is just repeating what you've already heard. If he has capacity, he can accept or refuse any and all treatment, even if it might lead to his death. This was not the case, let's say 60 years ago in Western medicine. 60 years ago, even 50 years ago, medicine was much more paternalistic and would have stepped in and probably performed the operation and the amputation over and against his refusal of that operation. But these days, in Western medicine, autonomy reigns supreme. And the rest of this is repetitive from previous slides at this point. Look at the question lower right. What if Mr. Sweet lacked capacity? Guess what? If he lacks capacity, he cannot refuse needed care. He can't leave the hospital against medical advice. So people leave hospitals all the time against medical advice. And the acronym for that is AMA. So they leave AMA all the time. But before they leave AMA, guess what? Someone like me needs to go in as a psychiatrist, or the medical team needs to assess, is this person able to make the call to leave against advice and refuse care? They can if they got capacity. But if they lack capacity, they can't leave against medical advice. They also cannot be discharged to homelessness or any other not safe enough situation. Someone with capacity, that even if they're homeless, they can say, I want to leave this hospital. I want to go back and live under the bridge where I was living before. And if they've got capacity, as painful as that might be as a human being, ethically, we need to respect their right to make that call. Once patients are deemed to lack capacity, who's going to decide for them? This varies from country to country and state to state. I'll tell you what it is in the federal system here in the United States. But if someone lacks capacity, there's a hierarchy of surrogate decision makers. So surrogate decision maker is the person who acts as a surrogate for the person who is incapacitated. Number one, this is the big one. Agent under MPOA is medical power of attorney. So if there's a formal written document signed by that individual when they did have capacity, or if a guardian has been put in place by the courts, that's the first surrogate. So even if the person, and look at number 2 down here, spouse, even if the person has a spouse, if they have signed documents or they have a court-appointed legal guardian, then whoever they designate in the signed documents or whoever the court-appointed guardian is gets to make the call, not the spouse. If the person doesn't have either medical power of attorney or legal guardian, then the next person in line is the patient's spouse. Remember what I said earlier, that sometimes law and ethics disagree. Well, get a load of this. We've seen situations where someone is married to a spouse, but they haven't lived together for 20 years. They just never formally got a divorce. So they're still legally married, even though they might not have seen each other in a decade or two. They might hate each other. And the patient might have been living with a new girlfriend or boyfriend or whatever for the last decade, but they have never gotten married because the person never got divorced in the first place, right? Legally, it's the spouse, the married spouse, who gets to make the call, even though ethically, I think everyone on this call would say, that's ridiculous. You haven't seen the person in 20 years and they're the ones who get to make the call. Again, so there's a discrepancy there between what's legal and what the law says and then what ethics says. But nonetheless, here's the hierarchy. Someone who's been appointed in writing, number 2, spouse, number 3, adult children, number 4, majority of adult children, and so on and so on. You can see how the rest of this goes. So what are the standards by which a surrogate decision maker ought to make decisions for someone where we say that person lacks capacity? The best and highest up on the list of how a surrogate decision maker ought to make choices is because They know exactly what the person wants, who they're making decisions for. How do they know it? Well, maybe they put it down in writing in the form of an advance directive. So the person may have written down, if I'm ever in a coma, here's what I want, here's what I don't want. If I've ever in a car accident and I can't be revived, and I'm never going to have a meaningful quality of life afterwards, here's what I would like, right? So if they have written that down, that's awesome. Or if you've had repeated conversations, like over and over and over the years, the person said, if I ever need dialysis, just let me die. Or if I ever need dialysis, keep me alive no matter what, give me as much dialysis as you could possibly. So however they talked, if the surrogate decision maker knows what they want, that's the best way to go. If the and that's what we prefer in the ethics service, because it just makes it easy to say we're doing what the patient would have wanted. The second best option is substituted judgment. This can come up where you say, I don't know what the person would have wanted in this particular situation, but I think what they would have wanted because of these external factors and so on is the following, right? Values, goals, and beliefs. The third one that we go to quite frequently also is best interest. What does the medical team think is in the best interest for this person? And the standard here is, what would a reasonable person want, right? You don't have to maximize everything. So that doesn't mean that you have to give CPR to a 99-year-old person who has metastatic cancer, right? Best interest might say absolutely not in a situation like that. It just depends. But nonetheless, these are the various standards by which surrogates make decisions on behalf of other people. Futility is a different concept. We haven't talked about it yet, but this next case is one where people might say, hey, this treatment is futile, meaning it's not going to help at all. So here's case number 2. Mr. Worth is an 85-year-old man dying of metastatic lung cancer. He has a large extended family, including a daughter who is his healthcare medical power of attorney. He goes into a deep coma. The attending physician recommends that a do not resuscitate and do not intubate order be placed. So when people are made DNR, do not resuscitate, generally what that means is if their heart stops pumping, there are not going to be exhaustive efforts to pound on their chest and to inject them with life-saving drugs. They're going to let the person die if that's ultimately what happens, or they may revive, but they're by themselves, but they are not going to have medical intervention if their heart stops beating. So here's this man, 85 years old, he is dying already, we know that. He's got metastatic, not just lung cancer, which is bad enough, but he's got metastatic lung cancer. But the family says this person, and because I work at a VA, I use the example of a veteran, could speak for himself, he would want an attempt at resuscitation. Why is there discomfort? There's discomfort on the medical side because in these situations, most of the time, medical teams do not like the idea of trying to resuscitate people who are near death anyway. As you may know, when you do attempt CPR to resuscitate someone and you're pounding on their chest, frequently ribs break. It is not a passive procedure. It is very, very aggressive, and medical teams are happy to do it if they think there's a good chance of reviving someone, or someone is otherwise young and healthy and their heart has just temporarily stopped beating. But frequently medical teams do not like to perform CPR in situations like this. So there's lots of distress when a family demands, or an individual demands, that if their heart were to stop beating, they would like it resuscitated. So to make this case a little more complex, everyone on the medical team strongly believes that performing CPR would be futile, and if anything, would cause harm for the reasons I was just saying. After 2 weeks in the intensive care unit, the person is still alive, still in a coma, and the family still wants him to remain full code, which means to perform CPR and intubate him if necessary, should his heart stop beating. So the teams get really anxious in these kinds of situations. Now I'm going to throw in a new wrinkle. The newest variant of COVID has caused the ER to be flooded, and many patients are actually just being housed in the ER or in the hallways, and they're waiting for inpatient beds, including beds in the ICU. So some of the patients who are in the ER need the intensive care unit. Mr. Worth is still in the intensive care unit. There is basically no chance that he is going to ever walk out of the hospital a healthy man, and yet he's occupying a bed that someone else might need. How does the medical team proceed now? Should the bedside team consider resource allocation? It's a good question. I don't really know the answer. In some situations, chiefs of staff or other hospital personnel may step in and actually take Mr. Worth out of the intensive care unit, put him into a regular hospital bed, which would almost definitely hasten his death, for the purpose of trying to put someone into the intensive care unit who actually has a chance of benefiting from the care. So it really, at this point, comes down to resource allocation and decisions made by medical staff members in situations like this. What exactly is futility? There are various definitions and expressions of futility, and many of them assume value judgments, such as what kind of life is worth living. So down here, this last point, futile care, you should not use that term futile care. Certain treatments are futile, meaning they're not going to produce a beneficial result or save somebody or whatever. We'll get onto that in the next slide. But care itself, you can continue to care for patients even if you withdraw treatment. So I just want to point out that these are not mutually, that futile treatment is one thing, but please don't use the term futile care. So there are several views on futility. I'm just going to go through these somewhat quickly. The first one is physiologic futility. Intervention is not reliable, expected to produce its intended physiologic outcome. So physiologic futility, for example, trying to get a heart beating that can't, no matter what, ever start beating again, right? It's just not going to happen. Or if a liver is completely cirrhotic, meaning it is full of cirrhosis and it is a dead liver, no matter what we do, we're not going to get that liver to come back online and be effective in its job as a liver. Imminent demise means even if we provide treatment that brings about some physiological good, right? We do get the heart beating or, something like that. Overall, if the person is is facing imminent demise, the person overall condition cannot be reversed to prevent their imminent death. There's clinical or overall futility is another one, and then quality of life futility is also one where even if we can save someone, they're never going to achieve a quality of life that they themselves would deem is good enough, right? So there are just different ways of thinking about futility, and anytime you're talking about futility, it bears noting which of these you're thinking of. Care can be inappropriate rather than futile, so sometimes it's good to get out of the talk about what's futile or not and think more about what's ultimately appropriate. And what are the duties of doctors in these situations? Obviously, non-maleficence to prevent pain, disability, and suffering. We also want to promote goods for the family, and the issue of justice comes in that last case scenario for Mr. Worth, when the latest COVID variant is flooding the ER, the demand for ICU beds is greater than the availability of those beds, and then questions of justice come in, as in who most deserves in the intensive care unit bed. this doing everything does not always mean doing the right thing. So when patients say, I want you to do everything, just save me no matter what, that frequently is not the right thing to do. There are certainly times when withholding care, I'm sorry, see, there I even said it, withholding certain treatments is the right thing to do in a given clinical situation. There are times when aggressive treatments just will cause more suffering than benefit. For example, I would say doing chest compressions on a 90-year-old person with metastatic cancer who is comatose, that, to my mind, brings more suffering than benefit. You don't need, as a doctor, to offer everything. It's just not necessary. And then I have one more case scenario I want to talk about, and this is very similar to a case we just had, and then I'll wrap up pretty shortly. This is a 60-year-old man who's morbidly obese and suffers from schizophrenia, and a spinal lesion that resulted in bilateral lower extremity weakness and being wheelchair bound. So he's really large, obese, his legs don't work, and he's got lower extremity weakness. He's lived in a nursing home for years, was pronounced incompetent by the courts 2 decades plus ago. He's got a guardian, and on a routine screening, he's got a positive fecal occult blood test, meaning they sample his stool, they find a little speck of blood or some kind of blood, and gastrointestinal doctors recommend colonoscopy. That's just standard. It's a screening test for colon cancer. He screens positive. Now they're recommending a colonoscopy, and his guardian says, yes, go for it. The patient is very alert, and he understands simple things, and he repeatedly, over many days, said he doesn't want to prep for the colonoscopy or have a colonoscopy. And you're like, well, what does prep for mean? Before you have a colonoscopy, you have to clean out your entire bowel by drinking a pretty, some people like it, but most people say it's a very foul tasting liquid over a period of a couple days or 3 days. And you drink this foul tasting liquid, and then you basically start having diarrhea nonstop for 3 days, or as long as you're drinking that liquid. And so you need to not only ingest the liquid, but it's very time intensive and very messy to prep for the colonoscopy. And then to have the colonoscopy, you have to go along with many different steps along the way to actually have the procedure, be made unconscious, et cetera. So even, and here's a case, the patient lacks capacity. So he can't really ethically refuse, but practically speaking, what would it mean to override his refusal? And by the way, he doesn't, the additional complicating feature is he can't walk on his own, he's wheelchair bound. So just think about even prepping for the colonoscopy with the many episodes of diarrhea you're going to have over the several days of prep, just impossibly, in my mind, almost impossibly difficult to do with someone who's wheelchair bound and refusing. So it just ends up being such a mess, literally and figuratively. But here's what you have to weigh. He just tested positive on a routine screening. The chances of him actually having colon cancer are probably very small. So even if he had the colonoscopy, it likely would be normal. Small chance it would be abnormal. And then you would have the additional thing of, okay, well, it's abnormal. Now we're going to get him to go for colon surgery. Sure. So just a mess all around. And really you have to start thinking about the possible benefits of absolutely forcing a treatment that logistically becomes a nightmare on someone who doesn't want it. And so you're balancing practical concerns with ethical ones. And finally, I'll just stop here. Again, we don't have to offer all medical and surgical treatments, only the reasonable only the reasonable ones are the ones that ought to be offered. Just because we can do something doesn't mean we should do it. We should identify a surrogate decision maker and medical power of attorney for any patient who is lacking capacity. Again, to repeat, we should never say futile care. We should only say certain treatments are futile. Care is not futile. And also stopping treatment, again, does not mean stopping care. And with that, I will stop sharing my slides. I would like to say thank you so much for having me. Complete pleasure. And if you'd like to be in touch, my email is my first initial J, Wesley Boyd, MD @gmail.com. So J, WESLEY BOYD MD @gmail.com. Thanks again. Take care.